Here's a quick and very simple summary of some of the cardiology things we've talked about in the 2012 paramedic class in recent sessions, as well as the paramedic refresher class this past week. We've talked about the importance of 12-lead EKGs. 12 leads give you more views than straight limb leads, and they give you more high-definition views, give you more ability to see subtle changes, and that is diagnostic quality. You cannot make sound decisions on ST elevation and other finer points unless you're in diagnostic quality, which means a 12 lead. We need to get 12 leads before we give nitroglycerin whenever possible. The nitro may obliterate some of the changes that were there, and our first 12 lead will be our best chance to catch that and identify some underlying pathology for the patient. We're looking for ST elevation or depression, ST changes. Those ST changes must be in contiguous leads. Contiguous leads are those that are numerically in order, such as 1 and 2 and 3, V1, V2. They're contiguous to each other, or they are anatomically contiguous. So if you realize that lead 1 and lead V6 look at the lateral wall, those are contiguous. Once you've identified the ST changes and you want to look at which leads have those ST changes, verify that you have contiguous leads. And now that you look at where the changes are, look at where those leads are looking. Look at what parts of the heart, which right ventricle, left ventricle, and look at where those leads are looking, and that will help you identify what's going on in the patient's heart. At that point, think about which vessels are feeding those areas so you can anticipate other problems. For instance, if you're seeing changes in the inferior wall, changes in lead 2 and 3 and AVF, and you realize that those leads 2, 3, and AVF are looking at the inferior wall, and you remember that the right coronary artery feeds that inferior wall, you can also potentially anticipate problems with the right ventricle, since the right coronary artery feeds the right ventricle, as well as the SA and AV nodes. Then you look for bundle branch block and axis. Axis helps you identify Hemi blocks. The reason we're doing that is to look for these conduction issues and anticipate a problem before it happens. Anticipate complete block or asystole before it happens to you suddenly. So that's where bundle branch and axis fits in. With the 2012 class, we have not gotten to this part yet, but this is where it fits in your overall analysis of 12 lead. And then the last point is make sure that a 12 lead becomes a part of your vitals. Serial 12 leads are very important. Every time you take a pressure, take a 12 lead. We've also talked about some blocks. AV blocks we'll talk about first. First degree AV block is a P for every QRS, and the PR interval is constant, but it's simply getting longer. This is not really a concerning situation. It may be just simply from too much vagal tone, too much parasympathetic discharge. Atropine would help with that should we decide that this patient is symptomatic. Rarely is first degree block an issue. Second degree type 1, also called Winky block, has lengthening PR intervals. There is a P for most QRSs until there's a QRS dropped, but the PR interval is lengthening, and that's what differentiates type 1, second degree type 1 or Winky block, from the other types of AV block. Now, this is also not a particularly big deal unless the ventricular rate is very slow. Second degree type 1 AV block can be caused from ischemia, maybe conduction disease, which is actually, I'm told, more common than it being cardiac ischemia, and vagal tone, excess parasympathetic tone may be causing this. So second degree type 1, Winky block, should be responsive to atropine in those few cases where the ventricular rate is so slow that your cardiac output is impacted. Moving on to second degree type 2, now this is a more concerning rhythm. Sometimes these complexes will be narrow, sometimes they will be wide. Obviously when they're wide they catch your attention. But a second degree type 2 has a constant PR and then simply drops a beat. And when you think about it, if it's dropping every other beat or every third beat, then the ventricular rate is going to be very slow. If it's dropping every fourth or fifth or sixth beat, then perhaps your ventricular rate's still going to be okay and your cardiac output's going to stay up. Second degree type 2, called Mobitz 2, is caused by disease of the conduction system, sometimes by ischemia, not very often, if at all, from excess vagal tone or excess parasympathetic activity. So atropine's not going to be very effective there. The concerning thing about second degree type 2 is that it's almost a warning that the patient's going to go into third degree block potentially. So these are patients to be very concerned about. Third degree block is where the P waves and the QRS waves have no relationship. The P rate is constant and usually at a decent rate. The QRS rate is not constant. It's usually a ventricular escape, so it's going to be slow in the 20s, 30s, 40s typically. And then it's that slow heart rate that will drop your cardiac output and causes a problem. So the P rate and the QRS rate, if you'll allow me those terms, are not related at all. It's complete AV dissociation. We have the same causes and concerns as with second degree type 2. Basically, second degree type 2 and third degree, it's all about the ventricular rate. Now, atropine is a possible treatment for first degrees and second degree type 1s. Probably not going to do any good for you on the second degree type 2s or the third degrees. Atropine is only taking away the vagal stimulation, the excess parasympathetic tone, if that's in place. It's not going to do anything to fix the conduction. It simply takes the brakes off that may be slowing the rate. Transcutaneous pacing is also an option. That simply bypasses the whole thing, and you generate your own P wave electrically, externally, and that will help get your ventricular rate up to where cardiac output stays up. And then positive chronotropes, in our case epi, dopamine, those will help fix some of those ventricular rates that are too slow. Again, they do nothing for the conduction, but they simply support that ventricular rate. Another kind of blocks are bundle branch blocks and Hemi blocks. We haven't talked about this yet with the 2012 paramedic class. We talked about it with Refresher the other day a little bit. Bundle branch blocks involve a ventricular conduction defect, where the impulse comes from the SA through the AV, everything's working fine, but then the conduction through the ventricles is slowed, producing a wide QRS and in some cases a slower rate. If there's no impulse coming supraventricular, coming from above the ventricles from the SA or AV situation, the ventricular pacers are going to fire at their own intrinsic backup rate in the 20s, 30s, 40s, and that's probably too slow to maintain legitimate cardiac output. And so that's where the conduction issues come into us. The point we want to make is there's only 3 lanes, there's only 3 ways to get an impulse to the ventricles: through the right bundle or through either half of the distal portion of the left bundle, the left anterior hemi, or the left anterior fascicle, I should say, which we talk about as the left anterior hemi block, or the left posterior fascicle, again abbreviated with LPHB, meaning the left posterior hemi block. So what you want to do with your 12 leads, look for that bundle branch block. V1's a real good lead for that. Use your turn signal to remember that if you need. And then look for your bad axis. Some of us are used to looking at a primarily negative QRS in 2 and 3 and having that be our signal. Others are simply letting the 12 lead machine generate the axis number for you and then referring to some charts. And so I think we'll need to put together a cheat sheet for you there, a reference sheet, because most people find that stuff hard to remember. So anyway, when you see bundle branch block, Hemi blocks, what you're worried about is this progressing to complete block, in which case you would need to have your chronotropes and your transcutaneous pacer ready. And what we're looking for is to help you remember when you see a right bundle and one of the 2 left fascicles, so a left anterior hemi block and a right bundle, or a left posterior hemi block and a right bundle, that should be a big warning sign to you. And so that's where this fits in. These are these patients that if you turn your back on them for a second, they're in complete block or asystole, and we want you to be able to see what's coming at you down the road. So then we talked about positive chronotropes, the 2 tools in our toolbox pretty much for increasing heart rate. Positive chronotropes are dopamine drip and epi drip. This screen we're talking about dopamine drips. Dopamine's pretty cool. Its effects depend on the dose. So as you turn up the drip rate, you're going to get different effects. More of the effects that you wanted up to a point, but then also different effects. At over 10 mics per kilo per minute, you're getting alpha effects, which under that you have very little alpha. So as you titrate the drip rate, you're also getting different effects, different beta 1 versus alpha. Infusion pump's helpful, but absolutely not required for most patients of in the 50 to say 100 kilo range. If the infusion pump is slowing you down, then you can just hang the dopamine drip and then look for a chart and fine-tune things later. But we don't want you to be held up in fear of or not wanting to deal with a dopamine drip when your patient needs one because of some infusion pump logistics problem. Dopamine drips are cool because they come pre-mixed. Most of the services that we've surveyed are using the 1600 mics per mil, so they end up with 400 milligrams of dopamine, and a 250 gives you 1600 mics per mil. And the rules of thumb that I have here on this are based on that mix and that mix only. If you have a different mix, you're not going to be able to use these rules of thumb. But the key thing is to have a couple rules of thumb so you can get that drip going, and then buy yourself some time, buy your patient some time for you to get your drip chart out, fine-tune this, or get an infusion pump and make it exact. So it's kind of like get water on the fire, and then we're going to try to determine a little more closely how we're going to attack it. If you need a chronotrope, hang you a dopamine drip for smaller people, 100-pound people, hang it at 15 drops a minute. If they're big people, 250-pound people or so, start it around 30. That will get you started, buy you some time. Now at that rate, you're only getting beta 1 effects at 2 to 10 mics per kilo per minute. So in that 15 to 30 drop initial range, based on whether it's a 100-pounder or a 250-pounder, that's only getting you beta 1. That's only going to increase your rate, so you get positive chronotrope, and you're going to get some positive inotrope. You're going to get some increase in stroke volume. It's not getting you any alpha effect. There's no vasoconstriction effect at that first starting dose. If you need vasoconstriction, if you need that alpha because your container size is too large for whatever reason, again, rule of thumb, then it's double your initial. So if you were going to start for your 100-pound patient at 15 to get you some beta, well then start at 30 and get you some alpha. And the same thing on the 250-pound patient. If you were going to start at 30 just to get your beta 1, then start it at 60, and that will get you a fair amount of alpha, buy you some time, look at a chart, and get you an infusion pump. Another key point here that I didn't put text on the slide for, but we'll just say, is to realize that once you get up to 10 mics a kilo per minute, you've got all the beta you're going to get, but you keep getting the beta as you start moving through the alpha range. So you have maxed out beta as you start to titrate into your alpha. And at 20 mics a kilo per minute, you have all the beta you can get and quite a bit of alpha. Last one here is the epi drips. I'll be real quick on this. These are usually a quick mix. You can put a milligram in 250, either use one of your 10 cc 1 milligram preload epis, or pop one of the ampules of the 1 milligram 1 milliliter vial of 1 to 1,000 epi that we hardly ever use. If those are in your first in pack, that might be a quick way to mix one, and just start it at 30 drops a minute. And there's a typo on the screen there, I apologize for, 30 drops a minute. So an amp in 250, 30 drops a minute, that will get you some vasoconstriction and some chronotrope. So you're going to get alpha and beta 1 from epi. The faster you turn it up, the more impact you get from both of those. 30 drops a minute starts you at the low end of the dose range. So again, get the drip hanging, and then get your chart out and fine-tune some things. Your max rate's going to be 150, so if you're in 30 to 60, you're still fairly on the low end. It's a little bit slower to mix this if you don't have 250 cc bags, if you only got 500 or 1,000s. Obviously for 500 you'd put 2 milligrams of epi in there. For 1,000 you got to find 4 of them to put in there. And then I think at least one service we are affiliated with only carries 100 cc bags in their jump kit. So again, you could put a milligram in that 100 cc, but then you want to start that at 15, which will keep you down in that low range, and your range is only 15 to 30. So we hope this summary helps. Went through it pretty fast. We'll do some other presentations that dig into this more deeply, but this is kind of a decent summary of what we've done in the last few sections of the 2012 paramedic class. Pretty much the first semester, and up to this point we've talked about some of this, and then the first 2 sessions of the 2012 paramedic refresher class, kind of a summary of the cardiac portion of that. Thanks for listening.